Hello. So we will talk in this video how to make an obstructed airway unobstructed. So airway is that pathway which atmospheric air takes to reach the alveoli. So if any obstruction happens in this pathway, the air will not reach the alveoli and patient will go into hypoxia. So it's an emergency condition and immediately we need to make it unobstructed. So let us assume I received a patient and the patient had airway obstruction. There was noise coming on breathing and the saturation of the patient was dropping. Immediately I have to do some maneuver to make the airway unobstructed. So we have two maneuver which does not require any device for making the airway unobstructed. One is head tilt, chin lift, and other is jaw thrust. So very quickly, I would take a quick history whether to know the patient is trauma or non-trauma. So we will just divide it into two broad division, trauma, non-trauma. So let us assume this patient is a non-trauma victim with an obstructed airway. So in a non-trauma victim with an obstructed airway, the maneuver of choice is head tilt, chin lift. Head tilt, chin lift is a single maneuver. What do we do? How do we do head tilt and chin lift? In head tilt and chin lift, with one hand, I tilt the head of the victim backward and with my other hand, I lift the jaw upward. So this is head tilt chin lift. Now what will this head tilt chin lift do? This maneuver will lift the tongue and prevent it from falling on the posterior wall of the airway, and it will create unobstructed pathway. The pathway was obstructed by the tongue was falling on the posterior wall of the airway. So by head tilt and chin lift, I lifted the tongue and created an unobstructed pathway. Now when I am doing this maneuver, you are noticing that movement is on head and neck joint. Head and neck joint is not in the neutral position. So when this movement on head and neck joint is happening, we cannot let this movement to happen in trauma victim. This movement can be allowed in non-trauma victim, but in trauma victim, where we suspect there's a possibility of cervical spine injury, we don't want any movement of the head and neck joint. So we need to keep the head and neck joint in neutral position. So let us assume this is a victim post-trauma with obstructed airway. I would not do head tilt chin lift. In this victim, I will keep the head and neck in neutral position, right? Like this, head and neck in neutral position. Stabilize the head and neck with both my palm, and with my thumb, I will open the mouth of the patient, and with my lower three fingers, which will be on the mandible, I will lift the mandible and protrude it forward. This is called jaw thrust. So jaw thrust also does the same thing. It also lifts the tongue without having any movement on head and neck joint, right? So these two maneuvers are the basic maneuver which we do to make an obstructed airway unobstructed. First was head tilt chin lift. Head tilt chin lift, with one hand I tilted the head backward and with other hand I lifted the chin upward. Now in this maneuver, head and neck movement, joint movement was happening. So this is maneuver of choice in non-trauma victim. For jaw thrust, I kept head and neck in neutral position and I protruded the mandible forward. This is the maneuver of choice in trauma victim. So these are two maneuver which we do, right? These are basic airway maneuver. Now when I am doing this maneuver, my hand is engaged. So I need some device which will keep my airway unobstructed and will make me free as well. So for that, we have two very important devices. We call it basic airway device. One is your oropharyngeal airway and the other is nasopharyngeal airway, right? Oropharyngeal airway is in my right hand, nasopharyngeal airway is in my left hand. So let us first talk about oropharyngeal airway. So this is oropharyngeal airway. As the name suggests, oropharyngeal. So it is inserted from oral cavity and remains in pharynx. So let me first tell you the parts of oropharyngeal airway. Now this is flange. The flange remains outside the oral cavity. This is bite block of the oropharyngeal airway. Since we are inserting it from mouth where we have teeth, patient can bite it and obstruct it. So to prevent it, a bite block has been put in this. Then this is the body. You can see the curvature of the body. It is curved, and in this only the tongue will be lifted. And you can see this is the oval tip. Some of the OPA has oval tip, some can have round tip as well. And there is a channel through which we can do the suctioning also through oropharyngeal airway. So this is oropharyngeal airway. This is made up of medically used plastic, right? So how do we insert it? Now, I am holding in my hand one oropharyngeal airway. This is a second oropharyngeal airway. This is a third oropharyngeal airway. I mean, some of it is in my hand. What I'm trying to tell you, that it comes in various sizes because we have to insert it from a small child to a robust adult. So it comes in various sizes. And first thing which we do when we have to insert it, we have to choose the correct size. So how do I choose the correct size? We always keep some assorted sizes ready. So how do I choose the correct size? I choose the correct size by measuring from angle of mouth to angle of mandible. So flange, this is the flange. I keep the flange on the angle of mouth and the tip should come on the angle of mandible. So this should be the correct size which will go into this patient, right? Now let me pick up another and show you, or first the smaller size. So I have put the flange on the angle of mouth and the tip is not coming on the angle of mandible. Now this would not be the appropriate size because if I will insert it, it will not cover the entire length and the tongue will fall, tongue will not get lifted. So we would not be able to lift the tongue with this device. And if I use a larger size, let me show you this size. I have put the flange on angle of mouth and the tip is far away from angle of mandible. So this is the larger size for this patient. So if I use this will stimulate the posterior pharyngeal wall and it will itself cause obstruction. So we don't want to put a larger size, we don't want to put a smaller size. We want to use the right size. And right size, how do we determine? Again, I am repeating, from measuring from angle of mouth to the angle of mandible. So I have chosen the correct size. How do I insert it? Now the easiest way to insert it is upside down method. Now if you see this oropharyngeal airway, it remains in the oral cavity like this, right? It remains in the oral cavity like this. But when we insert it, we hold it in upside down position, opposite direction, right? Like this. And then what we do, we insert it through the oral cavity of the patient, half inside, then I rotate it to 180 degree and then I push it. You're getting my point? So this is how we insert the oropharyngeal airway, upside down method. Now there are other methods as well. I can use let's say, vagal forceps and lift the tongue, right? The obstructed tongue, I can lift it with the forceps and I can insert it just as it will remain in the oral cavity and then put the tongue on the oropharyngeal airway. So this method can also be used, or I can insert it in lateral way also, not in upside down, just in lateral position also. Half inside, then I rotate it to 90 degree and then I push it. This will also do the job, okay? But the commonest way of inserting is the upside down method, in which we are holding it in upside down, right direction, half inside, and then I rotate it to 180 degree and then I push it. So this is how we insert it. As you can see, this flange is outside the oral cavity. This will prevent the forward migration of the oropharyngeal airway, right? The bite block is just against the teeth. It will prevent the patient from biting the oropharyngeal airway and causing obstruction. And in the body, the tongue is lifted. And through this channel, I can also do the suctioning of the patient. So I can use a suction catheter. I can insert it through the oropharyngeal airway and I can also do the suctioning of the patient. That's why this channel has been provided. Okay, so this is oropharyngeal airway. So this is a good device to lift the tongue. But the issue with this device is that when you put it in a conscious patient, if my patient is conscious with an obstructed airway, then this will stimulate the reflexes of the oral cavity, the pharyngeal, the laryngeal reflexes, and can cause laryngospasm, gag reflex, etc. So it cannot be used in a conscious patient, right? We can use it in unconscious patient. This is the device of choice for an unconscious patient with obstructed airway. This is device of choice. But in conscious patient, we should not use this device. It will stimulate the airway reflexes and can cause obstruction. Got my point? So what we will do in conscious patient with obstructed airway. So in conscious patient with obstructed airway, we can use this device. What is this? Nasopharyngeal airway. So I'm holding two nasopharyngeal airway in my hand. Okay. So as the name suggests, it will go from nose, nares, and it will remain in pharynx. Please see this device in a very careful manner. Now this looks like a short endotracheal tube. I'll show you. This is my endotracheal tube, which I will discuss with you. Now, if you see the end of the endotracheal tube, it is beveled. We call it pointed. The nasopharyngeal airway, the end is also pointed. It is also beveled. So these are the two devices whose end is beveled. Now this endotracheal tube goes past the glottic opening and this nasopharyngeal airway remains above the glottic opening. I can say it is a short endotracheal tube and it doesn't have a cuff because cuff, for why do we need cuff? I will talk about in endotracheal tube to create a seal in trachea, but nasopharyngeal airway remains in the oropharynx, so it doesn't have a cuff. So this is nasopharyngeal airway. Now this is made up of a very soft material, silicone, which can be easily tolerated even by a conscious patient. So it is used in a conscious patient with obstructed airway. So how do we use it? So two are in my hand. It also comes in assorted sizes, many sizes. So to use it, first thing we need to do is choose the correct size. How do we choose the correct size? By measuring from tip of nose to ear lobule, right? So it should be from tip of nose or sometimes from ala of nose to ear lobule. So this seems the correct size for my patient. So how do I insert it? I would check for the most patent nares of the patient. If my patient is conscious, I may ask my patient that from which of the nares you have a better air movement. Now patient can say from my left nostril or from my right nostril, or patient can say from both of my nostrils, it's same. So I can choose in any in that case, but we always try to choose the better one. So after choosing the right nostril, what I will do, I would lubricate the airway. I will lubricate the nasopharyngeal airway with the, let's say, a lubricant, and then I will hold it in my right hand, and you can see the beveled end, which will face the nasal septum. So it will face the nasal septum, and I will insert it in a rotatory movement like this, right? I will rotate. I will just insert it. So what does nasopharyngeal airway do? Now this nasopharyngeal airway, the parts I haven't told you. This is flange, which will prevent its migration into the nasal cavity. It will prevent it further migration into the nasal cavity. This is the body and this is the tip. Now, what does this nasopharyngeal airway do? Does it lift the tongue like your oropharyngeal airway? No, it doesn't lift the tongue. What does it do? It creates a free passage for the air to pass. This end, the beveled end, is just above the glottic opening. So now the atmospheric air can pass from this and it can reach the glottic opening. It can reach the glottic opening. So this is creating a passage for the air to reach the glottic opening. This is nasopharyngeal airway. So these are the two basic airway devices: oropharyngeal airway and nasopharyngeal airway. Oropharyngeal airway is the airway device of choice in an unconscious patient with obstructed airway. Nasopharyngeal airway is the airway device of choice in a conscious patient with obstructed airway. Now, what is the problem with nasopharyngeal airway? You insert it from nasal cavity, so there's a risk of nasal bleeding because nasal cavity, we all know, is a very vascular area, right? So we try to give vasoconstrictor drops prior to inserting nasopharyngeal airway, like xylometazoline or adrenaline if we don't have much of the time, and if in our patient I can give adrenaline, which can cause vasoconstriction. So we try to decrease the vascularity of nasal mucosa. But anyways, nasal mucosa is very, very vascular. The risk of bleeding is always there. So we do not put it in unconscious patient. If we put it in unconscious patient and bleeding will start, then aspiration can happen. We always put it in a conscious patient. So conscious patient with obstructed airway, nasopharyngeal airway. Unconscious patient with obstructed airway, oropharyngeal airway. Got it? So these are the basic airway devices which I talked about. So fourth thing till now I have talked. I talked in basic airway management, two maneuvers: head tilt, chin lift, and jaw thrust, and two simple airway adjunct: nasopharyngeal airway and oropharyngeal airway. Head tilt, chin lift is maneuver of choice in a non-trauma patient with obstructed airway. Jaw thrust is maneuver of choice in trauma patient with obstructed airway, right? Because jaw thrust doesn't cause the movement of head and neck joint. Then I talked about oropharyngeal airway, nasopharyngeal airway. Oropharyngeal airway is the device of choice in unconscious patient with obstructed airway. Nasopharyngeal airway is device of choice in conscious patient with obstructed airway, right? So these four devices I discussed. So guys, whatever I have discussed till now, these are the basic airway devices, and these devices do only one work: make the airway unobstructed, right? Make the airway unobstructed. Now, if I need to secure my airway for more work, like for ventilation, right? For, let's say, to give the anesthetic gases or to prevent aspiration to happen in the patient, then we need to put advanced airway devices, right? Advanced airway devices is what I will discuss now. But before talking from basic to advanced, I want to talk about one more very important airway maneuver which we should know: how to do bag and mask ventilation. So you can see this, what is in my hand? This is a face mask. This is an anesthesia face mask. You can see it has a narrow tapering end and a broad base, right? Which will guide us how we have to place it on the face of the patient. So this is my patient. For bag and mask ventilation, the narrow portion comes on the bridge of the nose like this, and the broader portion goes on the chin like this, okay? So this guides us how to keep it. Then how do we make a seal with this face mask? With the C and E technique, what we call it C and E technique. With my hand, I make C and E. How do I make it? This is my thumb and this is my index finger. My thumb and my index finger would be on the body of the mask, and it will create a C and it will apply a pressure downward. And my lower three finger would be on the mandible, would be on the bony prominence of the mandible, and this will lift the mandible. So with my thumb and with my index finger, I am pushing the mask downward, and with my other three fingers, which is making a E, if I have a pen, I would make it a E. This is lifting the mandible, and by this I am creating a seal, C and E technique. Then what I will do, I will pick up this. This is, what is this? This is a manual resuscitator, popularly called ambu bag, but this, the better name is manual resuscitator. So I would attach this manual resuscitator after creating a seal, and then I will ventilate. I can see both the lung of the patient is getting ventilated. So this is bag and mask ventilation by C&E technique. Now, number of time my patient is obese, the neck is very, very thick, I am not able to make a proper seal with my one hand. Then in that case, what we do, we make double C, double E. So I will use my other hand as well. I will use my other hand as well. What I will do, I will take the thumb, the other hand thumb and the index finger, and with my other three finger, I'll put on the mandible and I will lift it. The same thing, double C, double E technique. So this is also creating a seal, and one of my friend will help in ventilation. So this double C, double E technique we do when we are having difficulty with one hand, okay? With one hand, if I'm able to ventilate my patient as I can do in my patient, I would just go for one hand bag and mask technique. Now guys, this bag and mask technique can be life-saving for your patient. Now, if you know how to do bag and mask ventilation, you can save life of your patient, right? Even if you don't know how to put the advanced airway devices, because this will provide your patient with necessary oxygenation and will do the ventilation and can preserve your patient till the help comes. You're getting my point? So bag and mask ventilation is one let's say skill which you should always learn how to do it, okay? Now let us say that bag and mask ventilation, if I am not able to do, if I am not able to make, even after my full try with C&E technique, I am not able to do a proper bag and mask ventilation. So what are the rescue things which we can do? Now, the number of time tongue is falling right? Then also, if you do a bag and mask ventilation, because of the tongue fall, there will be a obstruction. So in that case, whatever I have taught you, use of oropharyngeal airway, use of nasopharyngeal airway, we can do that. We can put the, let's say, the oropharyngeal airway, or we can put the nasopharyngeal airway. Now this will create an unobstructed pathway in the oral cavity and help in our bag and mask ventilation. Or sometimes, if I don't have these devices, only the bag and mask, I can simply do a better head tilt and chin lift and better jaw thrust, because head tilt, chin lift and jaw thrust also lifts the tongue, right? So the four maneuver which I taught you, the basic airway maneuver, can help us during difficult mask ventilation by lifting the tongue and creating a passage for the air to pass by mask, right? So this is bag and mask ventilation, which I talked about. Now guys, let us talk about advanced airway devices. Now in advanced airway device, I would talk with you two type of device. What is this? This is a endotracheal tube, right? And what is this? This is a laryngeal mask airway. Endotracheal tube, as the name suggests, it goes into trachea, right? So it's an infraglottic airway device. The laryngeal mask airway, this remains in the oropharynx. This is supraglottic airway device. This doesn't cross the glottic opening. It is supraglottic airway device. So I'll talk about supraglottic airway device. I'll talk about the infraglottic airway device, endotracheal tube. So let me start with the less invasive one, that is supraglottic airway device. So let us talk about supraglottic airway device. So this is prototype of supraglottic airway device. This is a classical laryngeal mask airway. Classical laryngeal mask airway. As you can see, this has a mask, that's why we call it mask, and it has a tube which is used for ventilation. So it's a combination of mask and tube. And if you see this mask, the mask is same like your face mask. So masks, the shape is same like your face mask, the narrow and the broad portion. You're getting my point? So if I just tell you the parts of this laryngeal mask airway, now this is the mask, let's say, which is attached to a pilate balloon system to inflate it. We have a cuff surrounding the mask. This is the cuff surrounding the mask. This is the opening on the ventral surface of the mask, which would be helpful for ventilation. So one end of this opening would be against the glottic opening and other end would be outside the oral cavity for ventilation. So what we will do, from the other end, we will attach the circuit or the manual resuscitator, and this end will go in, just will remain above the glottic opening, and I can ventilate the patient. So my distal end is above the glottic opening and my proximal end is outside for ventilation. Okay, so this is the cuff which has a mask and a surrounding cuff which is attached to the pilate balloon system. It has, as you can see, opening, and this is the dorsal part which is smooth. So how do I insert it? Again, like any airway device, we have to choose the correct size. So if you see this device, now this also comes in assorted size. We have various size, a small size, a big size I have picked up in my hand, right? We have number of sizes available, right? Choosing which size would be appropriate in my patient depends upon the body weight of the patient, right? So let's say in my hand is size 2. It is written here, it is size 2. And for what body weight this is appropriate, this is also written. So it is appropriate for 10 to 20 kg, for a person between weight 10 to 20 kg. So we would use it for a person between 10 to 20 kg. Now let's say this is a laryngeal mask airway. This is the size which is appropriate for an adult between 70 to 100 kg. So we get different sizes, and according to the body weight, we choose the correct size. For a normal adult, normally size 3 in women and size 4 in male patients would be appropriate, right? So how do we insert it? How do we insert it? To insert it, you have to first deflate the cuff. So let me see, I will deflate the cuff. I will have to check that first. I will inspect the laryngeal mask airway. It should not be broken anywhere. The cuff should be intact. Then I will deflate the cuff. I would deflate the cuff. So I have deflated the cuff, as you can see. After deflating the cuff, I would always deflate the cuff by putting it on a hard surface like this. I will deflate the cuff. After deflating the cuff, what I will do? I will lubricate the dorsal part of the cuff. I will lubricate the dorsal part of the mask, right? So I have lubricated the dorsal part. Okay. Then I will hold it in pen holding fashion at the junction of tube and the cuff. So this is the junction of tube and cuff. This is the cuff and this is the tube. So I hold it like pen, as I am holding now, like pen. Then I'll make the patient in a morning stiffing position. What is morning stiffing position? Head of the patient is extended, neck is flexed. Morning stiffing, head extended, neck flexed. I will hold the device in my right hand. Always, the airway devices are held in your dominant hand. Maximum population, the dominant hand is right hand. Mine is also right hand. I am holding it in my right hand. So I would hold it in my right hand at the junction of cuff and tube, and with my index finger, I will guide it and I will push the cuff towards the posterior pharyngeal wall. So I'm pushing, 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 pushing till I can push. Now, I cannot push any further. I am facing maximum resistance. Now, it is not going inside anymore. So what I will do, I will leave it there and I will inflate the cuff. Now, on the tube of the LMA, it is also written how much air we should inflate in the cuff of this particular supraglottic airway device. So let's say in my this device, I have to put 12 ml. So I will just fill the 12 ml of air and I will inflate the cuff. I will inflate the cuff. So when I inflate the cuff, the LMA takes its position and little bit it comes outside when it takes the position, right? When it takes the position, little bit comes outside because it gets inflated. So little bit it comes outside. So then once I see this, and very important thing, it should be in the midline. See, there is a line on the back of the LMA. I'll show you. This line should be in the midline, right? It should be in the midline. All these indicates that it is at the right place. So I have inserted it. Little I have inflated the cuff. Little it has come outside, right? And then I will connect and I will inflate. I will inflate, right? I will connect and I will ventilate the patient. So I can see both my lung is getting ventilated. You are getting my point? So this is how we insert the LMA. If this is not ventilating, I would try to choose the next higher side. So let's say this is not the appropriate size. This is size 2.5. Then I will pick up the size 3 for my patient, right? So I would go for one size higher. Okay, this is your laryngeal mask, the classical laryngeal mask airway. Now this is first generation supraglottic airway device. Lot of improvisation has been done on it. I'll show you another device. Now this is iGel airway, another supraglottic airway device, and this is second generation supraglottic airway device. Now you can see this device, it has a airway tube, it has a gastric tube. Now this device has only one tube and there is no opening on the tip of the mask. But in our second generation supraglottic airway device, we have two tubes, one airway and one gastric tube. This is the gastric tube which is attached to the airway tube side by side. And this gastric tube ends on the cuff and there is opening here also. And through this gastric tube, I can put even the Ryle's tube, right? I can put the Ryle's tube and I can deflate the stomach of the patient. Okay, so this is iGel. This is iGel, a second generation, right? So how do I insert it? To insert it, the first thing which we do, choose the appropriate size. By seeing the body weight of the patient, it is written that the size which I have picked up in my hand is size 3 and it is written it is appropriate for between 30 to 60 kg. So my patient is, let's say, 55 kg. I have chosen the size 3. So I have chosen the right size. After choosing the right size, I would lubricate the cuff with the jelly. So I have lubricated the cuff properly and then again I will hold it in pen holding fashion from at the junction of cuff and tube. So I am holding it in a pen holding fashion like this at the junction of cuff and tube. And then what I will do, I will just again with help of my index finger, I will push it towards the posterior pharyngeal wall. So I am pushing it towards the posterior pharyngeal wall. after making the patient in morning sniffing position. Morning sniffing position, head extended, neck is flexed. So I made the patient in morning sniffing position and I am pushing the LMA right towards the posterior pharyngeal wall till I face the maximum resistance. Now here I cannot push it any further. So here I am facing maximum resistance. So after that, what I will do, I would just attach my manual resuscitator and I will ventilate and check, right? If again I am not able to ventilate the patient, chest rise is not there, I would use the next size, higher or lower, right? Depends upon let's say body weight of the patient. So I would choose the next size. So this is how we put the supraglottic airway device, right? This is your second generation and this is your classical LMA, which is first generation. We have ProSeal LMA also, which is also second generation, right? So second generation supraglottic airway device will always have two tubes, one gastric and one airway tube. And it will have cuff and it will have, let's say, two openings as well, airway opening and the esophageal opening. Now this tip of the supraglottic airway device goes on in hypopharynx, on esophagus, and the opening in the cuff, right, on the ventral part of the cuff remains against the glottic opening. So this remains against the glottic opening, the tip goes in the hypopharynx and we are able to ventilate the patient. Okay, so these devices we are able to ventilate the patient. Now let's say I'm not able to put this device as well and I'm not able to ventilate the patient, then I can go for endotracheal intubation. So now let us talk about endotracheal intubation, right? Now what are these in my hand? These are endotracheal tubes. These are ET tubes, cuffed endotracheal tubes. As the name suggests, it goes into trachea, right? It goes into trachea through the glottic opening. And we can insert this endotracheal tube by two means, either from nasal cavity or from oral cavity. Orotracheal intubation, nasotracheal intubation. Now, nasal cavity, as I already told you, is very vascular, so we don't want to touch it. So normally we avoid nasal intubation, we try to do orotracheal intubation. For orotracheal intubation, we take the help of the device. This is, what is this? This is your laryngoscope. This is Macintosh laryngoscope or curved blade laryngoscope. You can see it has a handle, it has a blade and it has a junction which would unite together the handle and blade. So what did I do? First I assembled my laryngoscope after choosing the appropriate size of the blade which I would use in my patient. We have different sizes of blade also. The commonest one which we use is, let's say, size 3 in an adult patient. So my blade is also of size 3. So I checked the light of the laryngoscope, picked up the right blade of the laryngoscope. Now I'm holding the laryngoscope in my hand. I'm holding it in my hand. Now how do I use it for orotracheal intubation? The first thing, the first step in laryngoscopy is to make a proper position. So what is the proper position? Morning sniffing position. For morning sniffing position, head is extended and the neck is flexed. How can we achieve this? We can achieve this by putting some cloth or roll between the shoulder blade of the patient also. Or we can simply make this position, right? And we can maintain this position with our right hand. So I'm maintaining this position with my right hand. And in my left hand, I hold the laryngoscope. Guys, laryngoscope, this is Macintosh laryngoscope or curved blade laryngoscope, as I said. This is always held in your left hand. Now, what was the reason? No, your dominant hand should be free to hold the airway devices, So, my dominant hand should hold my endotracheal tube. And maximum population, the dominant hand is right hand. So, the shape of the laryngoscope was made in such a way that it should be held in left hand. So, I have to hold it in my left hand, right? After holding it in my left hand, I introduce it from right angle of mouth. As you can see, I introduce from patient's right angle of mouth, and under full vision I have to see that how the blade of my laryngoscope is going. We have to lift, what we have to do when I am introducing it, I have to push the tongue out of my vision. How do I push it? I move the blade from right angle of mouth to middle. When I do this, the tongue is pushed from middle to left side. When I do this, I change my grip from the junction of handle and blade to more towards the handle. Now I'm holding it like this. And then I introduce under full vision and see the epiglottis. Now I'm seeing the epiglottis of the patient. And what do? I lift the laryngoscope towards the roof of the room and I can see the glottic opening. So now I can see the glottic opening when the epiglottis is lifted up. And under full vision, I would put the endotracheal tube. So I have put the endotracheal tube under my full vision, right? After this, I would remove the laryngoscope. After this, I would inflate the cuff of ET tube. So I'm inflating the cuff of ET tube. Okay. So I inflate the cuff of the ET tube. So I've inflated the cuff of ET tube and then I would check for the right position. I will hold the ET tube at the margin of the lip. So I can see in my mannequin, both the lung is getting ventilated, right? Now, what is the best way to confirm that it has gone into trachea and not somewhere in esophagus? By capnography. I would attach between the tube and circuit or manual resuscitator a capno, and the gas which will go into the patient and come out will pass through that capno. And if it has carbon dioxide, a tracing will come. That's the best way. The other way is we can auscultate the chest of the patient, right? 5-point auscultation, abdomen and 4-point on the chest. And I can confirm the tube is at right place. So tube should be always confirmed. Once I have confirmed, then I would just disconnect the circuit or the resuscitator and I will fix the tube with the adhesives. I will fix the tube with the adhesive on the margin of the lip. Now, very important, I had told you how do we insert the tube. Now, you should know, once I have inserted the tube, you should know importance of every part of the tube. So this end is the B-weld end of the tube which goes into the glottic opening. Why this is B-weld? This is B-weld because when I hold, and this is left facing B-weld as you can see, when I hold the tube in my right hand, this B-weld end would not obstruct my view of tube crossing the glottic opening. Then just behind the B-weld end, you can see there is another opening. There is another opening. This is called Murphy's eye. If the tube touches the wall of the trachea, the ventilation is possible for Murphy's eye. So this is an alternate opening for ventilation. Then you can see this is the cuff with a pilate balloon system to inflate it. So we inflate the cuff, it forms a seal in the trachea. This seal is necessary for positive pressure ventilation. So when I have inserted the tube, I said I would always inflate the cuff and then I will check. So I have inflated the cuff and then I checked for the right position. Because if I will not inflate the cuff, there would be no, let's say, seal for positive pressure ventilation. So this cuff creates a seal for positive pressure ventilation. And this also prevents any aspiration to happen. Then you can see there is a black mark. There is a black mark on the tube. This black mark, we need to leave it at the glottic opening. This will help us in keeping the end of the tube above the carina. So let's say carina is the bifurcation of the trachea and you have to keep the ET tube above carina so that endobronchial intubation doesn't happen, right? To prevent it, we need to leave the black mark on the glottic opening. Then it is written what size, this size which is in my hand is 7.5. ID 7.5, internal diameter 7.5. The sizing of the tube is done according to internal diameter. Then the company is written, then single use, external diameter is like written, and then there are markings on the tube which tell us its distance from the glottic end. So when I have inserted it and I have checked it, I would see at what marking it is on the margin of the lip. So let's say in my patient it is 22. It is the tip of the tube, the glottic end of the tube is 22 centimeter from the margin of the lip. So if the tube goes inside or come out, I would know at the margin of the lip, it was at 22 centimeter. Now it is at 23 centimeter. Tube has gone more inside. So my tube has deviated from its position, which I had fixed. So to help us in knowing whether the tube is at right place or not, where I have fixed it. So there are markings on it, and there is always marking on the ET tube. Okay. Then this is universal connector to universally connect it to the circuit and to the other devices for positive pressure ventilation. So this is the universal connector, and you can see there is a blue line on the ET tube through and through. This blue line is radio opaque line, which will help us in seeing the tube through in chest X-ray. Okay. So this is how we insert the endotracheal tube. So again, I would say it comes in assorted sizes. You have to choose the correct size. So I have picked up 7.5. I have inserted in my patient 7.5 mm internal diameter tube. Normally in adult male we use between 7 to 8 mm internal diameter. In adult female between, let's say, 6 to 7 internal diameter ET tube, right? In children we have certain formulas by which we calculate the appropriate size. So it is according to the age the ET tube size is decided. For the supraglottic airway device, it is according to the weight. And for the other airway devices like oropharyngeal, nasopharyngeal, we have to measure the correct size according to the facial contour of the patient. Got my point? So this is how we insert the endotracheal tube. We do the laryngoscopy after making the proper position. How do we do the laryngoscopy? Again, I will revise for you. So let me take this ET tube out. Okay. So I just remove my ET tube after deflating it. So how do we do the laryngoscopy? We make a morning sniffing position, head extended, neck flexed, maintain this position with my right hand. Then I take the laryngoscope in my left hand from right angle of mouth. I push the tongue from middle to left side and see the epiglottis. I see the epiglottis. I take the tip of the laryngoscope to the base of the epiglottis from where it is hanging, change the grip and lift the laryngoscope towards the roof of the room. The movement is on the elbow joint, not on the wrist joint. So I lift it. I can see the glottic opening, and under full vision, I put the endotracheal tube. So this is how we do laryngoscopy, right? After putting the ET tube, I inflate the cuff, I confirm the right position, and then I secured it on the margin of lip. So this is how we secure the ET tube, and this is how we put the advanced airway device endotracheal tube. So we have discussed the basic airway devices and we have discussed the advanced airway devices. So any patient coming in obstructed airway, we increase the gradation gradually. If head tilt, chin lift makes the airway unobstructed, fine. We insert oropharyngeal, nasopharyngeal airway, and if patient can breathe, doesn't require any support in ventilation, we leave the patient like that. If patient requires support in ventilation, then we definitely have to put the advanced airway, right? So we put either supraglottic airway device or we put endotracheal tube. Now remember, endotracheal tube is the only airway device which is like 99.9% which can prevent aspiration. So if a patient is on long-term ventilation or mechanical ventilation, we always have to put endotracheal tube, right? So we have to inflate the cuff. This creates a seal in trachea and this prevents any aspiration to happen. Okay, so this is how we choose the airway devices, right? And I also talked about bag and mask ventilation. I hope you have understood. Thank you.